Welcome to the 8th in a series of COVID cases on the assessment and management of coronavirus in mental health settings. Again, welcome to colleagues at East London and outside of East London, and to medical students joining us from Barts and the London. So the session is for all our junior doctors, staff grades and consultants to share learning on coronavirus. We've started a little bit late today because we know that some of the new security measures might be delaying people joining the call. So there's going to be just 2 more cases in this series in total, next week and in 3 weeks' time. So huge thanks today to the frankly brilliant Cate and Lynsey McApline, who've led on the project and kept us all updated and contained over the last 9 weeks. Thanks also to all of our expert reviewers over the last 8 weeks, 40 of them in total over 8 weeks from 15 different organisations. This week, we're thanking higher trainees Dr. Fawziya and Dr. Adeola Williams, and also Dr. Josie Jenkinson, a consultant psychiatrist and older adult liaison at Surrey and Borders, Dr. Krishnan, chair-elect of the Faculty of Old Age Psychiatry, Dr. Bindman of the Royal London, the great Norman Poole, and Dr. Tony Rowd, consultant psychiatrist at South London and Maudsley. Thank you all for your help. Thanks also to all of you for your enthusiastic participation, and we welcome comments from you all and from the medical students at Barts and London as well. So over to you, Cate, for the case. Lynsey for updates.
Right, hi everyone. Welcome back for another week of COVID cases. All right, let's get cracking then. Okay, so a couple of updates to get us started. Firstly, we wanted to just briefly talk about anosmia. So this is something that's been brought up a few times in the presentations. And I think what we're seeing now is some emerging evidence that COVID-19 can present with olfactory or gustatory dysfunction as an early symptom, particularly in people with mild and moderate disease. I think at the outset of the pandemic, most of the evidence from China was saying that it probably wasn't a very common symptom, but I think more recently with some of the European studies, they're seeing it as a more common symptom. And the most recent meta-analysis found 53% of patients presented with olfactory dysfunction and 44% had gustatory dysfunction right at the beginning of their illness. So in keeping with that, the Department of Health and Social Care is now recommending that people who develop anosmia should self-isolate for 7 days and their households should isolate for 14 days in line with other COVID symptoms. The other update we wanted to give you was around the RCPSYCH guidance on assessment and management of risk for BAME staff. So the college put this guidance out last week, highlighting that 20% of our overall workforce is BAME, but it accounts for 2/3 of the healthcare deaths. They looked at some of the reasons for that and acknowledged that it's probably not just down to age, health, disability and socioeconomic factors, but probably down to more systemic inequalities and other disadvantages that people are suffering. They looked at a range of different studies from the GMC, from the college, from HE, and they looked at the workforce race equality standard as well to look at some of the reasons why people might be at increased risk of COVID if they're BAME. And they identified quite a lot of different things. So personal experiences of discrimination makes people less likely to raise concerns. They highlighted fewer BAME leadership role models and their increased precarity and reduced opportunity. And the feeling of having a limited voice in organisations is also quite a significant factor, because it means people can have reduced input into things like safe rotas, redeployment and decisions about working from home. They also sort of acknowledge that the lack of sense of belonging can have an adverse effect on people's sense of psychological safety. And they highlighted that BME people may be more likely to accept what's offered in terms of PPE, risky placements, unsafe rotas and things like that. Their guidance includes some quite helpful pointers in how this should be approached. So they're recommending a risk assessment for all BAME staff, and they give a risk assessment tool, although they highlight that this should be something that's used as a sort of starting point for a conversation rather than as a tick box exercise. And they say that by doing this sort of sensitive risk assessment, they can recommend putting into place some risk mitigation measures to reduce people's exposure to risk. And there's a whole range of different interventions that they recommend, things like access to PPE, testing, remote working, decisions around redeployment, and recommendations as well around things like vitamin D supplementation, avenues to speak up, and staff engagement. They also highlight some of the more broad organisational things that can be done, and acknowledge that there needs to be a lot more longer term work to improve organisational culture and capability.
And the only other thing to say about that is also that ELFT, I just saw on the website this morning, there's also going to be webinars and a guide to risk assessment from a local kind of perspective, so keep an eye out for that as well. Okay,
right, on with the case.
On to the case. All right. So once again, you're back on call. It's the weekend and you're in liaison. And the PLN has asked you to see a 75-year-old man who's been brought in by ambulance after he was found today at home by his carer. He was quite confused, paranoid, and he was saying to his carer that he thought she'd been sent to kill him. The carer thought he was a bit breathless and looked a bit sweaty, and she called LAS. And we know from what the PLN has told us that he's been under the older adult CMHT in the past with depression. So A&E have seen him and they've kind of documented this kind of query, shortness of breath and confusion. They haven't observed a cough. He doesn't appear short of breath in A&E, but he does appear confused and paranoid, and he's not able to really give them any history. He's got a past medical history of poorly controlled type 2 diabetes, below knee amputation last year. He's got hypertension, previous TIA, depression, osteoarthritis, and as almost everyone does, CKD stage 3. So in A&E, he's sort of got slightly low blood pressure, a bit tachycardic, sat to 95, respiratory rate of 20, his BM's 18, doesn't have any obvious signs of injuries. They think he's got slightly reduced air at his bases of his lungs, but no crackles or wheeze, and his abdomen's soft, calves are soft, non-tender, or calf, I should say, is soft, non-tender. And they plan to do a COVID swab, do some bloods, query medics, not quite sure yet, and they're going to ask for a psych review. So what other information would you want to kind of look for at this point before you start thinking about how you might approach Mr. P?
Should we go back and give them
the
information again? So this is what he's presenting with. What other information do you think you need to know? Everyone's really quiet this week.
Just going to wait for that slightly longer than comfortable amount of time in case people.
Yeah, there we go.
It's coming through now. Okay. So collateral history about his kind of baseline mental state, social circumstances, BM or. Yeah, so his BM's 18, but we could get a sense of his previous control. Has he been exposed to COVID? What meds is he usually on? Yeah, a few more votes for collateral history. Definitely very important with older adults, probably important with everybody, but definitely in contact with COVID. Okay, we'll keep going. So he is on Rio. So we can see from there that he is not currently open to the older adult CMHT. But he has been referred to IAPT recently by his GP late last year after his below knee amputation. He seemed to suffer some low mood after that. And he'd had an initial assessment in January 2020, which again just mentioned low mood. And IAPT have been kind of making phone calls every couple of weeks. And the last contact was about, I should say, a week ago. And his wife had been taken to hospital at that point with possible COVID. And he confirmed to IAPT that he's receiving government food parcels for vulnerable people, and his son's organised Ocado deliveries, and a carer was also organised for him. So he was under the older adult CMHT back in 2010. He was depressed after he retired, and he was treated with sertraline 150, had some CBT with the psychologist, and then was discharged the following year and did quite well, and no history of suicide attempts or admissions. So he's taking his sertraline still, Lantus, glycoside, metformin, aspirin, bisoprolol, ramipril, atorvastatin, and a low dose of amitriptyline. In terms of drug and alcohol history, what you can glean from the notes is that Back in 2010, there's a reference to a kind of daily bottle of wine in the assessment that's been scanned onto Rio, but the more recent IAP notes refer to possible harmful alcohol use, but haven't described the quantity. And there's no reports of illicit substance misuse, and he's an ex-smoker. Again, from the IAPT assessment, it says that he's a former head teacher. He's married to Mrs. P. She's also a teacher or retired teacher. He's got one son who lives in York and is a carpenter. He was born in Wales, son of a miner, attended grammar school there, and then studied literature and went into teaching. And he's got a family history of dementia with a mother who's died back in 2005, no siblings, and no forensic history. So you try and call the care agency because they're the ones that actually call the ambulance for him to kind of come into hospital, but you can't get through to anyone, so you've left a message asking them to call the hospital. And the next of kin is listed as his wife, and it's just a landline and there isn't any answer. And the number for son isn't listed in the notes, unfortunately. So it's a bit of a dead end there for now. So what do you want to do at this point? So we've got Mr. P, who's 75, he's come in with some possible breathlessness, some confusion. He's got a past history of depression. He's kind of waiting for some talking therapy for depression. But he's come in quite confused with some paranoia. Okay. Yep, so bloods, COVID. Go and have a look at him, do a mental state and wear full PPE. Yep, definitely some thoughts about wanting to kind of rule out medical causes. So yeah, some feelings that definitely he kind of needs some further medical evaluation. Bloods, urine dip, COVID test. Yep. So thoughts about possibly being worried about delirium. It's a good one. And because we're good liaison people, we'll go and kind of assess him perhaps at the same time as he's having some of these investigations. Some other thoughts about kind of constipation and his hydration status, definitely. I mean, he's a bit tachycardic, isn't he? And he's a bit hypertensive. We know his wife's been taken to hospital. There's potential that he could be malnourished or not drinking enough. All right, onward. So you don PPE, and you find him kind of in A&E. He's sitting up in bed. He's looking quite confused and frightened, very perplexed, agitated, a bit tremulous, and he can't really tell you how he came to be in hospital. He doesn't know where he is. He's wondering if his wife is here somewhere. He says he feels fine, but he just needs to get to see his wife. But then moments later, he's kind of looking behind you and asking who's kind of standing behind you. So he's a Caucasian man. He's got his kind of shirt buttoned up kind of over the top of some ECG stickers, which he's kind of pulling at. He's looking confused and frightened, as we said. He's tremulous. He's quite agitated, but he's definitely not kind of aggressive. He's trying to get out of bed, but he's not able to. And he's very hypervigilant, so kind of reacting quite a lot to any sounds that are going on outside the cubicle. Very difficult to kind of assess his mood. He sort of tells you he's fine, but it's not very convincing. His speech is spontaneous, but he often kind of goes off topic according to kind of what he's noticed in the room. And he's just kind of asking where his wife is. Doesn't seem to have any thoughts to harm himself or others, but he seems to be quite suspicious and quite frightened. You think that he might be kind of seeing something behind you because he keeps asking who's there, and he can't really tell you anything about what's been happening recently, what the date or time is. He can't recall your name when you ask a few minutes later, and you ask him to try and count back from 20, but he can't do it forwards either. So he's pretty confused. So what are your differential diagnoses at this point? So we've got, sorry, I should be letting you read out the answers.
That's all
I've just
right.
totally hijacked the whole thing.
Well, we're getting lots and lots of suggestions around delirium, delirium query COVID, some suggestions of dementia as well. So a lot of you are saying dementia, delirium. Does anyone have any thoughts about what might be causing the delirium? So we're getting some suggestions around alcohol withdrawal. Yeah. Cool.
Yeah.
Or an infection.
And a suggestion to check his medications as well. So question of whether he's on benzos before also could have been an option. Check his blood sugar. His blood sugar is 18, so a bit high, but sort of not in the, what's the new name for honk now?
HHD.
That's the one. So not quite in that region. So yeah, and one thought about agitated depression, which is also, yeah, he's got a history of depression, but yeah, okay. Move on. Sorry. So I guess this was the sort of list we came up with. So some kind of delirium. Again, it's sort of the cause is as yet unclear, but potentially COVID. I mean, he's certainly had a COVID contact because his wife's got COVID. Some kind of other infection, alcohol withdrawal, some sort of intracranial event or metabolic abnormality. And then I guess much lower down on the list, given the sort of presentation, a sort of psychosis and agitated depression. And just one other thought as well about checking his amputation, like his wound, whether he's got kind of sepsis from that. So yeah. So when you get back to the office, you can see that some of his bloods are back. So he's got slightly low hemoglobin with a macrocytic picture. He's got slightly raised white cells, but not hugely, and neutrophils of 7. Platelets are 160. He's got some kind of liver function abnormalities, but not major. And he's got normal TFTs, low vitamin D, as we've come to expect. And he's got a new kind of renal impairment from his baseline. So he did have some renal impairment already, but he's got a new renal impairment with a raised urea. And his HbA1c is 65. He's got a mild acidosis, and again a sinus kind of tachycardia on his ECG, and a chest X-ray that doesn't show any kind of vocal changes. And MSU's been sent for him, and no, unfortunately, no gamma GT was ordered at that time. So we don't know what that one is at the moment. Would be helpful. So. You can see that A&E have documented sort of that they're kind of doing an ongoing assessment. They've noted that he's got a new kind of AKI. They're saying query dementia, query psych. It's sort of not quite clear where this man's headed just yet. So that's kind of up for discussion. So what do you guys think should happen next to Mr. P?
So yeah, certainly it sounds like you might need some rehydration there. Some suggestions around admitting under the medics with some site liaison input. Yeah, again, some suggestions about medical admission, possibly the need for Pavernex, Librium, rehydration, and quite a helpful suggestion about a video call with his wife, if that's possible, might help to reorient him a little bit. Some queries around his nutrition, and again, people suggesting CWA scoring and Pavernex.
Excellent. So we've got a pretty comprehensive plan. So just because you want to be on the safe side and you want to run it past someone, you speak to the SPR and you kind of present the summary. So just recapping, 75-year-old man, he's got a history of depression, probable alcohol misuse, type 2 diabetes. He's been brought in with confusion, paranoia, and possible breathlessness. We haven't been able to get any collateral. He has had recent contact with a COVID positive person, but doesn't appear to have any kind of respiratory symptoms that are actively obvious to us at the moment, although he's got a new delirium. And he's got hypervigilance, paranoia, poor attention, concentration, disorientation, and possible visual hallucinations. So I think we've probably covered all of these. So we've got our main diagnosis at the moment. We've got delirium, possibly alcohol withdrawal, possibly infection related. And we think he needs a medical admission. So I think that's good. So you speak to A&E and you explain to them that he had a history of alcohol use, which wasn't something that they kind of picked up when they'd seen him initially, which is kind of why it's really helpful for us to share information from Rio that might kind of give us more background and kind of context to someone's presentation. And so putting all of those pieces together, they kind of agree that he may well have a kind of alcohol withdrawal delirium, but that further kind of medical investigations are still needed. And he's got an AKI, so he's going to need some IV fluids. And you sort of also stress at that point that this doesn't really look like it's kind of a depressive disorder, and the psychotic symptoms seem to be very much in the context of a delirium. So mental health admission at this point would not really be the most appropriate place for this gentleman. And so they agree to refer to the medics. So what else would you want to do? Again, this is kind of for the medical team more than anything else, but just to think about what else needs to happen at this point.
So yeah, right off the bat, we've got some suggestions around capacity assessment and whether DOLS is appropriate here. More suggestions around getting in touch with the family and whether there's any advanced directive in place. And repeating the sort of points mentioned before about Papernex and Lybrium, depending on his LFTs. I think in the longer term, thinking about drug and alcohol team involvement. And I guess with the medics, just giving them some clear instructions about what medication you recommend and what doses you'd recommend.
Definitely. Okay, so he is accepted by the medics, and he's still awaiting his swab, so he's kind of being treated as a kind of still high risk for COVID. And he starts some Papernex and IV fluids and chloride epoxide, Clexane, his metformin, his medications basically reviewed in light of his kind of new renal impairment, and GGTs added on to his LFTs. And he has a CT brain, given he's got kind of new confusion, and it's showing global atrophy with some disproportionate atrophy as of his cerebellar regions, and some mild small vessel disease. So potentially some signs of alcohol-related damage there. Given he's very agitated, he's sort of trying to swing his other leg over the side of the bed. A one-to-one is kind of arranged for the ward that he's going to, and a DOLS application is going to be made on the medical ward. And there's going to be continued attempts to contact his next of kin and the care agency as well. And although it's kind of difficult to know what his baseline is, it seems the estimate is that he's probably got a clinical frailty score of somewhere between 4 and 5, but there's kind of documented that further collateral is really needed to kind of estimate that. And for now, he's going to be for consideration of ITU, but it's felt that he probably should have a DNA CPR. So yeah. So over the next few days, his COVID swab comes back negative. Liaison have been giving phone advice to the medical team. He's doing well on a reducing regime of chloride epoxide, and after a couple of days, the one-to-one's able to be stopped. His renal function's doing a bit better with IV fluids. And the GP's been in touch with the ward as well. He heard that Mr. P's wife was in hospital, and he'd actually been in touch with Mr. P about a week ago to check that the carer was visiting, and that the food parcels were kind of being received okay. And he passed on to the medical team that he thought Mr. P was a bit flat, but he was kind of holding up okay, pretty kind of stoic guy, worried about his wife, but not too down. And that the GP was clear that he hadn't really had any concerns about Mr. P's cognition, hadn't been thinking about referring him to the memory clinic or anything like that. The sons also phoned the ward, having heard from the care agency that Dad's in hospital, and also spoke to the medical SHO. So he says that Mr. P's in a different hospital, admitted for COVID, but is actually recovering and hopefully going to kind of get home soon. He has told his dad about this, but Dad doesn't seem to remember now. He's been able to speak to him on the ward by phone, and he just says he seems really, really muddled. Mrs. P, when the kind of COVID pandemic started, Mrs. P started ordering Ocado and using the food parcels from the council. But when she went into hospital, his son took over as Dad wasn't quite managing the computer very well. And the son saw that in previous orders, they'd been ordering quite a lot of wine, but thought you know, everyone's drinking a lot during lockdown, but it's quite a good opportunity for Mr. P to cut down his alcohol intake, actually. And he basically refused to order any wine for his dad. And they did have a fight about this, but he remained pretty firm. So the last order hadn't had any wine in it. And there was a discussion about resuscitation status. The son kind of understood the DNA CPR and also kind of expressed he didn't think that his dad would want to go to ITU. So there's been further conversations about that at that time. So alcohol and COVID, I guess we've talked a little bit about this before, and it's all kind of all over Twitter, generally in a kind of joking way. But I guess it's really important to remember that older adults, like younger adults, may drink more in the pandemic for various reasons, but conversely may also have difficulty in accessing their regular alcohol. And that's potentially if they're relying on government food parcels, but they're having to kind of shield at home, but also the kind of difficulties and shame in having to negotiate with carers or family to get their alcohol for them. So there's potential for people to end up in withdrawal. And there's some helpful advice from RCPSYCH on kind of general management of alcohol during COVID. Again, it's about kind of identifying if someone's drinking harmfully but not dependent, in which case then you can kind of safely reduce. But if you're dependent, then you need to be aware of the risk of withdrawal. And really importantly, as you guys have all pointed out, which is, you know, the hospital's in very safe hands, and the brains of people who are kind of withdrawing from alcohol are hopefully in safe hands, because you're going to give people their Pabrinex and their chlordiazepoxide. And I guess the other thing to stress about that is we're all kind of aware of the triad of symptoms for Wernicke's, but really importantly, you know, the full triad is actually quite rare. So you have to kind of have a pretty, just go for the Pabrinex if you're not quite sure. Better to be safe than sorry. So over the next few days, the care agency have also contacted the ward. The manager really apologised for the delay. They've had quite a number of staff off sick, but particularly the one who'd been looking after Mr. P is actually now been off with COVID symptoms and is isolating. And the notes that they'd been keeping about Mr. P was that he'd been increasingly confused in recent days, was a bit off his food, seemed to have forgotten that his wife was in hospital. And they give some background to the care package, that it had been started just after Mrs. P had been put in hospital, because actually prior to that she'd been assisting with all Mr. P's kind of personal care and was doing all of the cooking and so on. So, of course, because it's COVID cases, you're back on call again, and you're covering A&E liaison again, and it's a week later and it's a Saturday. And you get a call from the med-reg who says that they're really struggling to manage Mr. P. He's got really confused again, and he's punched one of the junior doctors while they were trying to take bloods. And they'd appreciate some advice on how to manage his aggression. So what else would you like to know at this point?
So yeah, good question. Why were they taking bloods? Yeah, you might speak to them about a behavioural chart to try and get a sense of what's actually going on here. Yeah, a few suggestions around behavioural charts. Another question about whether there's any new temperature spikes. Is he taking his medication? What are his latest bloods, presumably prior to the punching incident? Any other recent changes? Has he been moved to a different ward? And what are his observations? It's a really, really key one. And I suppose included in that is, you know, his current blood sugar control. Some questions about whether or not he's constipated. Has he been eating and drinking? And is he on a one-to-one at the moment?
Yeah, definitely. Cool. So he actually completed his alcohol withdrawal detox the day before. So he finished with his last dose of chlordiazepoxide. He'd had a course of Pabrinex, which was continued actually for a whole week because there were concerns given that he'd kind of had quite severe confusion. and was potentially malnourished, and certainly had been drinking quite a bit before coming into hospital. He'd been seen by the liaison psychiatrist yesterday, which was Friday, and they noticed that he was kind of quite a lot calmer, still quite perplexed, with some ongoing poor attention and concentration, short-term memory, a bit low in mood, but no suicidal ideation and no further psychotic symptoms. And so the impression had been sort of resolving withdrawal delirium. And there were some sort of beginning kind of conversations about whether, when he could get home, could the care agency increase their frequency of visits? Could he maybe go home after the weekend? So then overnight on Friday night, on routine observations, he was found to be drowsy. I should say he was off one-to-one by this point, so he was just having regular nursing care. So he was found to be drowsy, not communicating, low SATs, had spiked a temp, increased respiratory rate, dropping his blood pressure, tachycardic with a BM of 12. And the oxygen was started. He was reviewed by the medical SHO overnight. A COVID swab was taken. Bloods were taken at that time. So his renal function's deteriorating again. It had gone back to its baseline. His CRP is now 70, raised white cell count. Troponin is raised, D-dimer's raised as well. He's got an ECG with no acute changes, but he's tachycardic. That shouldn't say AF, just ignore that. He hasn't got new AF. He's got peripheral consolidation in his chest x-ray, and he's started on some antibiotics for a possible hospital-acquired pneumonia, because he's now obviously been in hospital for that long. So then he was seen on the ward round on Saturday by the MedReg and the on-call team. So he's still febrile, he's still hypoxic, he's pulling his oxygen off, he's very agitated, he's pulled his IV line out, and he hasn't had his morning antibiotics. He can't get out of bed, but he's trying to swing his good leg over the rails again, and he's shouting at anyone who comes near him. And he did punch the junior doctor when they were kind of trying to put in a new IV and take the morning bloods. And they haven't been able to get a CT brain because he's too agitated. And the MedReg feels very confident that this man has delirium and that he does not have capacity. They feel quite happy about that. They're not looking for advice on that, but they would like some advice about sedation for him. So what do we think might be causing Mr. P's delirium at this point in time?
So a few votes for COVID. Pneumonia is also being suggested, particularly hospital-acquired pneumonia.
Yeah,
so there's quite a consensus here.
And I think there was a suggestion also, which was really helpful before, just a mention of whether or not he'd been kind of detoxed too quickly. So or whether he'd kind of missed doses. So really helpful to look back through the drug chart. God, sorry. I blame COVID for that, to see whether he's actually had all of his chloride isopoxide. So we'll say that he had that. He'd had a complete detox. So it looks like it might be something to do with corona or pneumonia. So these were, I guess, the things that we think. He's got a delirium now, and of course there's all of the other things that could be contributing to that as well. Pain, urinary retention, constipation, uremia, any of the other kind of abnormalities that can contribute. Cool. So delirium in COVID. So these are the kind of factors that were identified by a paper that was looking specifically at delirium in ITU, hence the kind of mention of mechanical ventilation. But a lot of the other things are kind of relevant, I think, for anyone really. So there's concerns particularly about the fact that there is kind of direct CNS invasion, which we'll talk about shortly, but there's also kind of a huge inflammatory response, which of course has an effect on the brain. There's the secondary effects of other organ failures. There's the sedation that then gets used to kind of manage that. And there's the mobilization. And then of course, I think, probably we've been seeing a fair bit about this on Twitter about the effect of kind of isolation, the effect of PPE on communication with people who are already a little bit confused. You can add kind of bed moves and all that sort of thing to that. So there's a whole host of reasons that delirium might be more common in COVID. This is from that same paper, so I guess it kind of outlines all of these things in a much prettier way than we had on the previous slide. But I guess it's kind of also, it looks at some of the more systemic factors, so kind of also the increased workload on, in terms of healthcare professionals, the fact that people might be kind of really hot and tired in their PPE and burnt out, so they may not be quite as able to do all of that reorienting and all the fantastic delirium care that is starting to happen, or was starting to happen prior to COVID, but we'll discuss about that shortly. But I guess again, it's all of those things like being in strange environments and just the direct effects of COVID. So direct brain effects. So we know from previous corona type viruses that there have been associations with viral encephalopathy. There's some animal studies that suggest that the virus might enter the CNS through the olfactory bulb, hence the kind of anosmia. And that there can be subsequent infection of the hypothalamus and brainstem, and that's one of the reasons that it's thought to cause such severe respiratory failure. Again, it hasn't been proven yet, but there's thinking that the brainstem involvement might be why the respiratory failure is so severe. And then there's the potential for kind of direct entry sort of intranasally or indirect via the blood-brain barrier, but that's because of kind of a hyperinflammatory state, making the blood-brain barrier more leaky. And then there's a whole host of things. People are talking about cytokine storms, neuroinflammatory cascades, a whole lot of bad things going on in the brain, particles that shouldn't be found in the brain. So in other viruses, in SARS virus, they've found particles in the brain in deceased people, so it's making its way in there. Activated macrophages and microglia cause demyelination, and then demyelination causes a further inflammatory cascade, so a whole lot of badness in the brain, really. And there's a thought that the prolonged inflammation might be responsible for kind of the higher incidence of neuropsych abnormalities in people with severe infection. For this presentation, I swear every time I thought the presentation was finished, someone released another paper with neuropsychiatric. It's been, I think, it just means we're on trend, I think.
Yeah, we're ahead of the curve.
Definitely. So the first study, though, that has been out for quite a while was the study from Wuhan, which was the first study of 214 patients with COVID just generally, but they found that 36.4% of those people had neurological manifestations, which was quite a broad category of things, including any cerebrovascular diseases, impaired consciousness, or skeletal muscle injury. So quite casting the net quite wide.
Broad.
Yes. But more recently, we've had this review from Rogers and colleagues, which came out on Monday, looking at the kind of neuropsychiatric effects of COVID, which they also compared to SARS and MERS. And again, still really small numbers, and again, an ITU population, but they were seeing quite a bit of confusion, quite a lot of agitation, and interestingly, some executive dysfunction, even at the time of discharge from hospital. But again, very small numbers in the COVID group compared to the SARS and MERS group, but they did note quite high rates of PTSD, depression, and anxiety disorders in people that were recovering from SARS and MERS. So something that we'll talk about in one of our future kind of sessions. So Mr. P's second delirium, how do we think we should manage it? Because at the moment he's kind of punching the doctors, he's pulling out his IV lines, he's pulling off his oxygen. So we do need to probably do something.
So what sort of advice would you give to the medical team at this point?
I feel like there's going to be,
yeah, here we go. We just have to
either be a flood at some point. So one suggestion for low dose haloperidol, reorientation, get the one-to-one back, call his wife, maybe olanzapine, attention to kind of care, hydration.
quite a lot of different medication suggestions coming in. So some thoughts about low-dose benzos versus olanzapine versus low-dose haloperidol. Definitely not a consensus on what medication you'd recommend.
So as we all know, some good points about kind of managing delirium generally there. So there's also some BGS and RCPSYCH joint guidance, which takes us through all of the regular things that we need to do in delirium. So kind of orientation, treating reversible factors, trying non-pharmacological first. But there is a kind of caveat that an understanding that, especially within COVID, there might need to be a move to quickly go to pharmacological interventions if there's risk. Need to monitor if we do give any medication. And there's also kind of some advice about delirium information for staff, patients and family. So pinch me, favourite of the Homerton, just helpful mnemonic to remember all of the different things to kind of think about, which you can kind of treat and kind of do something about as you identify them. And some other tips about kind of communication generally, because I know we're all kind of worried about how we're communicating behind masks. The Toronto Geriatric Program has some really good tips also for relatives who are having phone conversations, like how can they kind of orientate someone by phone. So introducing themselves, reminding them very often, like, hi, I'm your daughter, it's good to see you, I saw you last a few weeks ago, you know, I hear you're in hospital, all those kind of things. So kind of prompting people. And then there's some thoughts as well about kind of how our posture and kind of approach might help reassure people who are very frightened. But I guess, and this is even from all of the people who are kind of usually very focused on the kind of non-pharmacological interventions, are saying, you know what, we're geriatricians, we're very into kind of gentle reassurance, but we're using a lot more antipsychotics than we normally do for delirium. This delirium in COVID, it's something else, you know, and actually it's kind of really undermining the severity of it to suggest that just kind of hand holding and phone calls are going to kind of treat this. So that's what the I'm not going to say frontline. Oh my God.
It's the anecdotal stuff. That's
anecdotal, yeah. So again, BGS and RCPSYCH have got a table of things. I guess importantly, you know, haloperidol is the only drug that is actually licensed to be used, but lorazepam and risperidone are other options. And I'm not going to go through this, but Josie Jenkinson has amazingly made this, you know, really cool table of things that might interact with other things. So antiviral agents, and there's also a COVID drug interactions link, so you can type things in and check whether things are going to interact. So really helpful to be able to kind of look that up when you're on call. So Mr. P, his previous ECG showed his QTC was 475. So what do we think is the best option at this point, given the information we have?
Some thoughts about repeating an ECG. I wonder how possible that's going to be if he's agitated, as you're saying.
Yeah.
It's probably a good idea if possible, but a bit of a challenge if he's very delirious.
Yeah, so some votes for risperidone, lorazepam, benzos. Yeah, so everyone will have their favourite option, and there probably is no right answer here. So we probably have to decide on something, because he's not getting any of his medical treatment, and that's kind of what he actually needs to get better from his delirium. So it's kind of a means to an end, but we have to do it as safely as we can. So we decide on the lorazepam because he's not benzo naive. He's already got a prolonged QTC. It's what we go for. He's offered it orally, but he refuses, and he's given some IM, and he is a bit calmer about 30 minutes later, but he's still not clinically doing very well. One-to-one's arranged, but they managed to get an IV line in and take some bloods again. So over the next 48 hours, he remains kind of intermittently agitated. He's getting a little bit more oral lorazepam, but he's tolerating the IV drip. And he has a video call with his son, but gets a bit confused by this. And then there's a phone call with his wife in the afternoon. He's having a kind of more lucid period, and he's really happy that she's home. He forgets that soon afterwards, but the one-to-one continues to kind of remind him, and his COVID swab comes back positive. So, did he contract COVID in the community prior to coming to hospital? Did he get it in hospital? Why was his admission swab negative?
It's a very important questions. What are your thoughts? So questions around a false negative and the sort of technique with getting the swab.
Mm-hmm.
And some potential suggestions that maybe they'd taken the first swab too early.
So false negative for some reason, but we're not sure yet. So right. So BMJ have also recently published a kind of practice pointer on testing. So what they've been looking at is the nasopharyngeal swab for viral RNA. Over all of the kind of reviews of studies, it's kind of estimated to be around 95% specific, 70% sensitive. And the review has suggested quite a range of false negative rates going from 2 to 29%. So it doesn't necessarily give us all that much clarity, and it depends on the stage of disease, the severity, the location of the swab. So if you take kind of a bronchial lavage, then that's much more kind of sensitive and specific, but nasopharyngeal is perhaps less so. So there's this kind of helpful pre-test, post-test graph that you can look at. So essentially a positive swab is pretty helpful. A negative swab in a situation where you still have a high pre-test probability doesn't necessarily rule out the disease. And I guess just to put it in context, I think we've talked about this a little bit before, but you know, the fever and the cough can come quite early, but the dyspnea can come later. So it could be that he did have some kind of episodes of fever at home, maybe a bit of cough or maybe no cough, and that his proper dyspnea and kind of infection started later, but we don't necessarily know. So on Monday, you're looking up his notes to see how he's been over the rest of the weekend. And unfortunately, on Sunday night, he became unresponsive again. And they did a CT at that time, and that showed kind of an acute infarct, loss of grey-white differentiation in the left occipital and parietal lobes. And he was felt not to be a candidate for thrombolysis. And his son and his wife had been informed, and they were going to continue with ward-based care and palliative measures at that time. So COVID and stroke, again, we've talked about VTE risk, and there's kind of a lot of anecdotal reports of kind of stroke-related phenomena. There's a case series from Queen Square. Their hypothesis is that there's kind of the pro-inflammatory cytokines, the endothelial damage, and then the kind of coagulation activation and thrombin. There's also some thoughts about antiphospholipid antibodies, but there's no causal relationship that's been established. But we've also seen from the coroner study, which we'll hear more about from Tim Nicholson at the BART this afternoon in a couple of weeks, is that there's been quite a lot of kind of case reports of cerebrovascular events. But again, just to stress, the coroner is all kind of people, reporting neuropsychiatric cases. So it doesn't tell us anything about kind of how common these are within a whole population who are getting COVID. It's kind of all of the exciting things that are happening that are being reported. So also just to mention, if you're interested in keeping up to date with what's going on in terms of neuropsychiatric manifestations, this JNNP blog is being updated weekly with a summary of all of the cases and all of the different kind of manifestations. And if you have something to report, you can also go on there and report a case if you've seen something interesting. So on Tuesday, again, you look at the notes and you can see that he's been unrousable, poor respiratory effort, and they tried to give him some oxygen, but he unfortunately died later that day. So sorry, it's a pretty sad end to the case. But I guess the key points to remember are that, we have to remember about alcohol. It's still, alcohol withdrawal can be a life-threatening condition, and delirium in COVID can be very severe, with particularly the direct inflammatory effects on the brain, as well as all of the other factors that affect normal delirium. And yeah, we do want to try non-pharmacological measures first, but particularly perhaps now and in urgent situations, we do have to make kind of decisions about some rapid sedation sometimes. So there's, yeah, I'm going to finish there.
Right, cool. All right, shall we hand over to?
Yeah, so I think we're just going to hand over to Paul for a brief update. Really encouraged by everyone's old age and alcohol withdrawal knowledge there. Thank you.
So old age and alcohol withdrawal, and then you come to speak to me. Were you making a point, Juliette, by any chance? So being older and not in alcohol withdrawal, I'll just give you an update on where we are with the trust at the minute and what's happening on our management of COVID as we move forward. You'll have seen from the government announcements and from the things you've been seeing in the news that we're moving into phase 2 of the pandemic management. The first phase certainly was a lot of organisation of services, getting everything in place, managing the wave of COVID that was presenting in our acute services, and trying to make sure as much as possible our service users and our staff were as safe as possible. We're now in a phase where the infection rate is certainly reduced, and we've now got a chance to start moving things forward. And in doing that, we have to think about what can we learn from that first spike of COVID, and how can we take this opportunity to make services improved for the future. So we've kind of changed from what we started off with, which was a very operational structure of management, into our phase 2, which is much more about learning and much more about how we develop and manage our new normal. So for that, we've developed 5 separate work streams, which I think cover most of the things and we think that are important at the moment. The first work stream is shaping our future services, and that work stream will be working with services to look at what did they do how did they change their services during COVID, and what did they close down, what did they build up on, and then to quality impact assess those changes so that we decide what do we really want to turn on urgently, what do we want to adjust before we turn it on, and what do we want to ditch. And I think the last thing is really important. The stuff we've realised when we switched it off, we don't really need it that much, so we can actually concentrate on the stuff that's important to us. The second work stream is future working. You will know that the government announced people to come back to work last week. However, for social distancing to take place, we have to prepare for people coming back to work. And how we manage that and how we do that is going to be important over the coming weeks. So we've said to our staff at the minute, don't come back to work if you don't have to. And then we'll have to arrange with staff as we move along about how we fit our services and our estates so that staff are as safe as possible and we can maintain that social distancing. So the future working will be working on that, and also thinking about what we've learned from working at home and how we balance that up with face-to-face working. The third work stream is leadership. It's our view that moving into the future, we will have to have our workforce will be very different in how they're going to be, how they're going to work. So we have to have a management and leadership team who are equipped to manage those changes. How do they manage the anxieties of their team whilst also having the anxieties of their own, from their own personal life and their own issues with COVID? So leadership and how we actually support our leaders and gives our leaders tools to actually move forward is going to be important. The fourth work stream is inequalities. Now, you've probably heard quite a bit about this already. Inequalities where we've seen a lot of poor outcomes of COVID in the elderly, as you've seen in this case here today. In learning disabilities, we've seen a disproportionate amount of deaths as well. And we have to really think, if we have to get a second spike, what did we learn from how we manage learning disabilities and old age that we can improve in the future if we were to hit a further spike in COVID? But other things as well, such as BAME, our BAME staff, our BAME population, and the disproportionate poor outcomes that they've had. We have to think about how we address that, and I'll come on to that at the end. And then lastly, the last work stream, which seems straightforward, it's unfortunately mine, is co-production. And that's to make sure going forward that all the work that happens within the organisation is co-produced with service users, co-produced with carers, co-produced with staff, and co-produced with other stakeholders. Now that sounds is probably one of the easiest work streams, but actually there's a twist in this because there's two other parts of the work in the co-production work stream. During COVID, our communities have done really creative things to build their resilience. If I give you an example of that, some streets have actually developed WhatsApp groups so that they make sure everybody's okay, and if they need some shopping, they'll go out and get some shopping for them. So they're looking after themselves much more. What we want to do is go out into our communities and find out how can we empower and enable our communities to maintain that resilience. How can we support them in continuing to move forward to building resilient communities? This is a once in a lifetime opportunity. We've got to do this. COVID has been a disruptor. It's disrupted our services, it's disrupted our lives, but we've got this opportunity to actually use it in a very positive way in changing how we provide services, how we support our communities and our populations, and how we empower and enable them. That's going to be quite a difficult thing to do, and we're just starting this group up now. But I think through our governors, who are real treasures that we have in our communities, and through our staff, a lot of you and a lot of people that you work with will live in our local communities. You can give us ideas, and you can tell us what's been happening in communities that you've found really, really worthwhile. So we're looking through workshops in a lot of different ways on how we actually tap into that seam, which I think is going to be a really, really important way to try and prevent or ease out the mental health surge that people are predicting will happen as we move forward. So those are work streams. They're in very, very early stages. We're just starting to scope them out. You will be hearing about them more as we go along. I suppose I just want to finish off in a final couple of minutes just mentioning about the BAME staff, because the Royal College has issued some work around about BAME, but there's also other vulnerabilities we've got with staff and thinking about how we protect staff. We've been working within our People and Culture department at looking at all the risk tools that people are using across the health sector and then pulling them together and making one for ourselves that will be actually built for just for ELFT. We've tested that out and we're hoping to get that out to everybody within the next week. So keep your eyes open for that. That will not only look into BAME issues, but also into physical health issues, into age, into gender, so that we can actually get a score. And then also look at, okay, if this is the score you have, what are we doing to mitigate that? Are you in the right place, and how do we make sure you're in the right place and you're being protected and made as safe as possible? So it's on its way. I know people have been really worried about that, but it should be with you in the next week. I'm aware I'm right on the dot in time, so I'm going to leave it there. But listen, in the meantime, thank you from all us at TrustH Quarters, and please keep safe. But we'll see you next week. Take care. Bye.
Thanks, Paul. Always good to hear what's going on. Thanks everyone for joining us. We'll let you get on, and thank you to all our peer reviewers again. We'll see you next week. Bye-bye.